Itoi
Hi,
Sensei,
hello.
hello. We are really glad to see you. You are welcome to our endoscopy event, and we can see you are on our screens. Let's start.
Okay, so thank you for kind introduction, Mihail, my friends, and hello everyone. First of all, I deeply appreciate the all organized committee, in particular the Mihail, and so for inviting me in this wonderful conference. So let's start my video, please.
Hello everyone, I'm Takao Itoi from Tokyo Medical University. Thank you so much for having me here. Let's get started my presentation. Nowadays, US-guided biliary drainage, USBD, is one of drainage technique which is emerging recently and including three types technique, namely EUS-choledochoduodenostomy, EUS-CDS, EUS-hepaticogastrostomy, EUS-HGS, and EUS antegrade stenting with or without HGS simultaneously. I guess EUS-HGS is the most popular technique in USBD because of its broad indication, which includes not only normal anatomy patients but also special situation patients, for example, gastric outlet obstruction or surgical altered anatomy. When you perform US-guided HGS, what kind of stent do you use for US-HGS? There are plastic and metal stents for US-HGS. Which one is better, plastic stent or metal stent? Here you can see the advantage and disadvantage of each stent. Looking at advantage of plastic stent placement, less traumatic, easy deployment, and easy exchange sound nice. In contrast, in my personal experience, it is sometimes difficult to deploy metal stent even by expertise of USBD. I guess for the beginners of USBD, deployment of metal stent is most difficult course of USBD. So we created a dedicated HGS plastic stent primarily for USBD beginners, and they have published nice outcome in GIE in 2015. Technical and clinical success were 100% and adverse event rate was 30.7% without serious one. Occlusion rate was 13.7% and median patency was 4 months. We thought it was very acceptable. In addition to that, at that moment, we summarized the outcome comparing between plastic and metal stent for EUS-HGS based on the published data. Surprisingly, there was no statistical difference between two stents. Since then, in our unit, plastic stent is the first stent for EUS-HGS, in particular for beginners. Interestingly, its dedicated plastic stent is developing year by year. The latest one is retractable integrated stent with seamless tip. I'd like to show the video. So firstly, needle puncture and the Doppler mode in order to avoid the intervening blood vessel and injection. Fortunately, we got a nice cholangiography. Then got a wire advancement into the CBD and looping. After tract dilation, using cautery dilate at this moment, and finally, 7 French plastic stent was placed, and EUS-HGS was completed. You can see an endoscopic image and the dark bile flows from the stent. Here you can see our outcome, including more than 200 cases in our unit in which EUS-HGS was performed mostly by my junior doctors. Technical success rate is 97% and stent migration is 0. So, how about the efficacy of plastic stent comparing to metal stent? Surprisingly, one report from Japan showed in 64 US-BD cases, including US-CDS and US-HGS, the time to stent dysfunction and 3 months dysfunction-free patency of plastic stent were superior to that of metal stent, although there was no statistical difference. Thus, there was no difference between plastic and metal stent regarding stent patency. Nevertheless, everyone still concerned about short stent patency due to its small caliber compared to metal stent. So, what should we do in order to overcome such theoretical concern? I think one of the important clue is to conduct not only hepaticogastrostomy but also simultaneous antegrade stenting using metal stent. EUS-HGS plus antegrade stenting has 3 theoretical advantages, namely, antegrade metal stent enables physiological bile flow with large bore metal stent, and HGS allows salvage drainage in case of antegrade stent dysfunction, like acute obstruction immediately after metal stent placement, and keeping access route using a plastic stent for reintervention. Moreover, if we use a plastic stent for HGS, patients save the medical cost. So, I'd like to show the video EUS-HGS plus antegrade stenting, so-called EUS-HGS, using a plastic stent for HGS. Firstly, the puncture transgastrically, needle advance into B3, and you can see nicely cholangiography. This case showed obstructive gastric outlet obstruction, and the duodenal metal stent was placed just before EUS-HGS. And so guidewire advance across the structure and into the duodenal metal stent. After measure the structure length and ultrasonic delivery system uncovered metal stent was placed across the structure. It looks nice. Double stenting in case of a gastric outlet obstruction and the obstructive jaundice. Finally, for re-intervention, we usually place the plastic stent for HGS route. Of course, in case of very dilated bile duct or special situation like a large amount of ascites, metal stent for HGS is acceptable, even in my unit. So, let's see our video. After Doppler mode, using a Doppler mode to avoid the intervening blood vessel, 19 gauge needle was advanced into the dilated bile duct, and the guide wire advanced across the stricture and the papilla into duodenum. And without any dilation, single delivery system uncovered metal stent was advanced. And slowly deployed, the fully deployed. And another end bear, 1 cm uncovered, partially covered metal stent was placed for the HGS route. You can see a very nicely drainage. It is EUS-HGS. From many years ago, we prefer EUS-HGS plus antegrade stenting, so-called HGAS. Here you can see the summary of EUS-HGAS, including our data. It is so nice. It is EUS-HGAS is better than HGS alone. Regarding the stent patency, so I think adding antegrade stenting to HGS provide even better patency. So here you can see the latest research comparing EUS-HGS and the HGAS from Japan. It showed EUS-HGAS provides longer patency than EUS-HGS alone. Interestingly, they conducted subgroup analysis. It showed there was no statistical difference between plastic stent and metal stent for HGS stenting in case of HGAS. So, ladies and gentlemen, in my conclusion, EUS-HGAS provides longer patency than HGS alone, and the efficacy of plastic stent is almost same as metal stent in HGS or HGAS. So, thank you very much. Thank you for your kind attention.
Thank you very much.
Itoi Sensei, thank you for your excellent report. And what is the situation in Japan? Does EUS drain of bile duct replace the percutaneous method of drain?
It is a good question. 20 years ago, still PT-BD is popular, even in Japan. But the recent 10 years, US-BD is most popular drainage technique in paired ERCP cases.
Okay. And one more questions for me, and maybe another from our audience. If you're going to drain left lobe of the liver, which segment do you prefer, the segment 2 or segment 3?
Okay, so if possible, in order to avoid, we can if we can avoid transesophageal puncture into B2. B2 is much better because the guide wire insertion and the guide wire manipulation is easier than B3 puncture. But so due to the scope angulation and the 19 gauge needle hardness, usually no choice to choose the B3. That's why. So basically, B3 is 60% in real world, but if possible, I want to puncture to B2.
Okay, thank you. Коллеги, one more question from our audience.
Yeah.
If the segment 2 of the liver you can visualize from the esophagus, is it the point to drain, or you choose the position and try to find other good view of the ducts of the liver?
Okay. So I think in case of B2 puncture transesophageus, the puncture. So I don't choose. I never choose a B2 puncture because B2 puncture transesophageal B2 puncture is very dangerous. It causes mediastinitis. So I have read that. That's why. So at that time, B3 is much better. Or if you want to perform a B2 puncture, I recommend 22 gauge needle and 0.18 guide wire, the puncture system. Otherwise, 19 gauge needle is sometimes very impossible to puncture into B2. Okay.
And what instrument do you prefer, needle or a cystotome to drain liver?
Good question. So many years ago, we used the 6-frame cystotome, as Shyam mentioned, for the cysto drainage. But so we compare the 6-frame cystotome versus mechanical dilator. Mechanical Sina dilator we have in Japan. At that time, after our study, we conclude the 6-frame cystotome is sometimes dangerous because it causes bleeding, right? Bleeding and immediate bleeding due to the burn effect of to the vessel. That's why. So recently, first choice is a mechanical dilator using a Sina dilator. But impossible in case we have to choose. We have to use 6-frame cystotome.
Okay, thank you. Okay, Itoi Sensei, we are really glad to see you, and thank you so much. Thank you for your time, and thank you
Thank you
very
very
much.
much. Yeah, yeah. I'm looking forward to going there.
Yeah.
Okay, thank you very much.
Okay, have a nice day.